Hello, Instagram. Okay. I almost couldn't wait till 11 o'clock, but it is 11 o'clock. So I'm going to start to talk about the iliotibial band, right? So I was talking to somebody, the reason I'm doing this is because I was talking to somebody about the iliotibial band or iliotibial tract, whatever you call it. I kind of fluctuate between the two. And about how foam rolling or treating the iliotibial band probably isn't the best way to get changes happening there. So I'm going to talk about three kind of different things that happen at the iliotibial band. And I'm going to apologize if you see my cat's tail in a second because he's sitting right above where the camera is. So the iliotibial band or iliotibial tract is found at the lateral aspect of the thigh, right? And it's really famous for getting tight and sore. And so one of the issues with understanding the iliotibial tract or iliotibial band is that it's really not a band at all. Tract is actually a way better description for what it is. It really is just a thickening of the fascia lata, or the fascia that wraps the whole entire thigh. And so where the iliotibial tract is just a thickening of that fascia. It's continuous with the entire thigh. And so the idea that it rubs against the lateral aspect of the knee, there's some type of friction syndrome that happens there, is kind of misleading because it's not just this band that flaps around, right? It acts like a tendon, but it's not separate from the surrounding fascia. So anyway, let's talk about the three things that can kind of happen there. When people have kind of generalized tension along the entire tract, so you've got a patient that says, my IT band is tight. There are a couple things that you might want to look for. If the entire iliotibial tract is tight, then you might want to look at the ankle and the hip, looking for instability at those two joints. Is there a history of hip trauma, hip pain, ankle sprains, those kind of things? Those will often lead to generalized tension along the iliotibial tract. In those cases, you might also find that someone points to tension kind of here, right? Along this inferior or the distal aspect of vastus lateralis, one of the quadricep muscles. They may even say that, they foam roll the distal end of the iliotibial tract, or this kind of part of the top of their knee, and it feels really good and gives them relief, but not for very long. So, entire iliotibial band, look at the ankle, look at the hip. I'm going to go a little further with that in a second. The second situation might be a relationship between TFL and gMax. So tensor fasciae lata. Tensor fasciae lata is this muscle at the front of the hip. It's small, right? It's fairly small muscle. It doesn't extend the length of the entire thigh. The tensor fasciae lata attaches to ASIS in the anterior part of the iliac crest, and then it attaches to the iliotibial tract and really to the tibia via the iliotibial tract, because we know the iliotibial tract attaches to the lateral condyle of the tibia, crosses the knee, attaches there at Gerdy's tubercle. So that's TFL. TFL inserts on the iliotibial tract. The second muscle that's really important is gMax. So gMax, that big butt muscle. So gMax has lots of attachments, right? Ilium, sacrum, coccyx, sacrotuberous ligament, thoracolumbar fascia, huge amounts of attachments, but its insertion is also the iliotibial tract and the gluteal tuberosity. Okay. Iliotibial tract though. So we have TFL and gMax here. gMax is an external rotator and an abductor, extensor of the hip. TFL, flexor, internal rotator of the hip. So they really do act potentially as antagonists, especially in a gait cycle. So there may be a relationship between those two muscles that are causing the iliotibial band to increase its tension. So if one or both are inhibited or downregulated, it's not really uncommon to see the iliotibial tract start to tighten up in order to provide perhaps lateral knee stability. The third situation, if you have somebody that has iliotibial band tightness or pain, and it's mostly distal, it's this like side of the knee kind of stuff, a good place to look is the fibula and some of the local tissue in that area. Is there increased tone? Are there issues with the movement or sensation at the tissues here in this local area? So those are kind of the three places to go when you've got somebody with iliotibial band tightness. Whatever word you want to use, doesn't matter. Are there other options? Certainly. I'm going to show you how you might use these relationships to figure out whether or not they are applicable to your patient or your client. Will this be saved? Yeah, it's going to be saved. So I will save it and repost it, this video. Okay, so the first thing you need to establish in order to know whether or not these relationships exist, and I'm just going to give you a few techniques for figuring out whether or not these relationships exist. Certainly apply your own skills. If you've got other skills, you use cups or you use tape, absolutely use those tools as well. I'm going to give you some clues, some concepts, and then you'll know how to apply it based on the skills you have. So the first thing you're going to need in any situation is you're going to need an outcome measure. So what is the thing that is aggravating for your patient or your client? Do they get reproduction of that pain or that tightness in the iliotibial band when they do squats, when they walk downstairs, upstairs, when they do single leg stance, when they stand from a seated position? Establish an outcome measure so that you can use that outcome measure to determine whether or not your intervention has created a change. So let's just say that our pretend patient gets aggravation at the spot in the iliotibial band when they do squats. So we're just going to use a squat, an air squat, sometimes people call it, as our outcome measure. So I do an air squat, I feel that pain. The first thing I could check is there local tension here in vastus lateralis? Is vastus lateralis all kind of janky because I have ankle or hip instability? So one way that I can determine if one of those relationships exist is I could do some soft tissue work here. If you're not a manual therapist, you don't have to do this. You could have them foam roll, gently foam roll, vastus lateralis especially. Vastus lateralis mostly because of how much it's related to the iliotibial tract in terms of location, and you'll often find increased tone there when the entire iliotibial band is tight. So some local work around vastus lateralis, stretch, foam rolling, really gentle, pain-free. Immediately after doing that, go back to your outcome measure, and as the movement coach or as the manual therapist, hold their ankle, provide ankle stability, or wrap it with voodoo floss, or wrap it with a tensor bandage. Have them repeat that. If you take down tone in vastus lateralis, give them ankle stability, hold their ankle while they repeat that aggravating movement, and it gets better. And pain goes away, pain decreases even by 10%. Maybe you found a relationship there. Can you release vastus lateralis? Calm that tissue down. No pain when you do it. Your aim is to decrease afferents from this tissue, calm this tissue down, gentle foam rolling, gentle manual therapy. Establish some stability at their hip, either by holding the hip. It doesn't need to be strong. It just needs to provide a little proprioceptive input to tell the brain, hey, this is safe. Have them reproduce the aggravating movement. Does the pain go down? Is it easier? Does range of motion increase? Then you've got a relationship. If that exists, then maybe your work is some manual therapy to tone down vastus lateralis and work on ankle or hip stability. The second relationship is that relationship between TFL and gMax. So TFL, also in terms of how TFL and gMax affect the pelvis, TFL tends towards anterior pelvic tilt, right? It's the front of the hip. So when it is short and tight, TFL perpetuates anterior pelvic tilt. When gMax is short and tight, it's a hip extensor, and so it will perpetuate posterior pelvic tilt. And so often what I see, especially in runners or cyclists, is a lot of tone or high tone in tensor fascia lata, and maybe a little down regulation of gMax. I don't like to say gMax isn't firing, because it is. It's just maybe put at a mechanical disadvantage. That makes it a little bit more difficult. So if I think that there is a high tone or upregulated TFL and a down-regulated gMax, that's contributing to this tug at iliotibial tract, right? Because both of them attach to the iliotibial tract. And if one is upregulated, one is downregulated, then you're going to get this uneven kind of tug along that fascia that might result in the experience of pain. So if that's the case, and I think, man, if I just could take down a little bit of that tone or drive in TFL, get that gMax to contract a couple times, maybe that aggravating movement, the squat, won't be so painful. So the way I might do that, again, I might foam roll, I might do some manual therapy, but I'm lazy. I like a 2-for-1. So the 2-for-1 that I would use is I would get down on that side knee. Can you see this? Yes. The other leg in front, so I'm in a 90-90 position, right? I'm in half kneeling. The target side knee is on the floor. My trunk is upright. I'm gonna squeeze this glute to down-regulate or inhibit TFL, up-regulate gMax, and then I'm gonna release. And then I'm just gonna repeat this a few times. If this TFL is really kind of high tone, then it might be a little bit more effective to do a little soft tissue stuff here. Again, gentle soft tissue stuff here first, and then come down into this half kneeling. So all I'm doing is I'm down regulating through reciprocal inhibition, TFL, up regulating gMax because I'm squeezing my butt hard, ugly hard, so you get like all the dimples, and then releasing, holding for a few seconds, and releasing. Now if I get my patient, or I come up, and I do that aggravating movement, is it so aggravating? Has that pain come down? Does my range of motion increase? That's a good relationship then to work with. The last one, number 3, the relationship between kind of this distal iliotibial band soreness and the fibula or the soft tissue in that area. Maybe the reason I'm getting this distal soreness in my iliotibial tract around the knee, that friction syndrome area, is because there's some local soft tissue stuff happening, maybe increased tone, upregulation, and maybe my fibula needs to be mobilized. That could be related to the ankle too, right? So maybe if I was having my patient do this, troubleshoot this themselves, I might be doing this virtually, so this is great to do virtually. I would have them kind of in a kneeling position and just place their hand, kind of grab the outer aspect, that lateral aspect of gastroc, and just gently self-massage that area, kind of mid-lateral gastroc, even up, take my thumb up and behind the knee, just super gentle soft tissue stuff. And then maybe I take the bottom of my hand and I push down on fibula. Just get fibula to move a little bit of mobilization of fibula. I can even use my other hand if your patient has the mobility to do it, and kind of pull fibula. So I'm pushing and pulling fibula kind of A to P, anterior to posterior. And then I get back up and I do that aggravating factor, that outcome measure that I've picked. Does it get better? Does pain go down? Does range of motion increase? Does it feel easier? Does it feel safer? Then that might be a good relationship to work with. So you need an outcome measure. What is the aggravating factor? Go back to that after you use an intervention. If the entire iliotibial band is tight, then look at ankle and hip stability being an issue. If you think that there's something happening at the pelvis, some stuff going on maybe in that sagittal plane, then maybe look at the relationship more specifically between TFL and gMax. I often find it's TFL needs to be down regulated, gMax needs to be up regulated, but anything can happen. And then the third, if the iliotibial band stuff is here, like that friction syndrome area, gently release local soft tissue, mobilize that fibula however you want to, not necessarily the way that I showed you. Do that outcome measure again. Does it change? If it does, that's a relationship you want to work with. All right, that's it. If you've got questions, put them in the comments. See ya.